Okay, so for our next talk, we are going to hear about how we leveraged similar rapid response pipelines now to undertake a study of shingles vaccine for the prevention of dementia. So for this, we'll be hearing from Dr. Katherine Li. Dr. Li is a postdoctoral research fellow at CAUSALab, who earned her PhD in population health sciences, as well as her master's in epidemiology and biostatistics here at the school. Her research is focused on using large health databases to evaluate clinical interventions and inform health decision-making. And as part of her work with the VA-CAUSAL Methods Core, she specifically focused on assessing the effectiveness of vaccines for various disease outcomes. So welcome, Dr. Li.
Thank you, Barbara. Hi, everyone. Today, I'm delighted to be here to present our research project on herpes zoster vaccine and dementia. I'll start with disclosures that this presentation only reflects the views of the authors and not the VA or the government. And also a disclaimer that the results I'm going to present today are not final and may be subject to change prior to publication. Observational studies have reported a 19 to 35% lower risk of dementia comparing recipients of the herpes zoster vaccine versus non-recipients. However, these results may be challenging to interpret because first, observational studies may be subject to design biases, such as selection bias introduced by conditional on post-baseline factors, like requiring a wellness visit during the follow-up. Second, there may be residual confounding, such as by health status or healthcare-seeking behaviors. Some studies used regression discontinuity design as an alternative approach to minimize confounding. They take advantage of the strictly applied eligibility of herpes zoster vaccine based on date of birth. But their results may not generalize to a broader age range that's away from the date of birth cutoff. Lastly, the majority of the studies only had a follow-up of less than 7 or 8 years, which may be insufficient for dementia outcomes because dementia tends to develop over a long period of time and the recording may be delayed. This is a high-impact clinical question because shingles vaccine is already recommended for use among older adults. And if they can also prevent dementia, then it will be really appealing. So in this study, we leveraged the infrastructure that Hannah just introduced to evaluate Zostavax and all-cause dementia over 10 years of follow-up using nationwide data from the VA. We also evaluated the potential for confounding using negative control and benchmarking to a randomized trial. The data that we used for target trial emulation includes the nationwide database of electronic health records in the VA, the largest integrated healthcare system in the US. It includes detailed information on demographics, clinical encounters, medications, lab results. It has frequent updates and it has long follow-up. We also included linkage to CMS and DoD databases to have more complete capture of the information of those veterans, especially for those over 65 years old. In this target trial, or the hypothetical pragmatic trial that we would conduct to study this research question, we would include veterans aged over 60 years old or over 60 years old between June 2008 and December 2018, without history of dementia, neurological disease, or a suspected dementia captured by some diagnosis or medications. We would exclude people with any indication of disability, any previous herpes zoster vaccinations, or contraindication for Zostavax, namely weakened immune system, because it's a live vaccine. We also require people to have a known address outside of long-term care and have a primary care visit in VA or through Medicare in the current month, and at least one primary care visit in VA and recording of smoking status and BMI in the previous 18 months. We're hoping to capture active VA users in this study. And in emulation, we did the same as for the target trial. We consider two treatment strategies. The first is immediate administration of a single dose of the Zostavax vaccine, and second is no immediate administration of the Zostavax vaccine. Under both strategies, individuals would not receive any subsequent doses of the herpes zoster vaccine over the follow-up. In the target trial, we would randomly assign individuals to one of the two strategies at baseline, and people will be aware of their assignment. To emulate this, we classified individuals into one of the two strategies according to their vaccination records at baseline. We assumed the two groups were exchangeable at baseline, conditional on the following factors, including calendar month, basic demographics, urbanicity, lifestyle factors, clinical factors, history of herpes zoster, comorbidities, frailty status, and markers of health and healthcare-seeking behaviors. We consider two outcomes, all-cause dementia and all-cause mortality. And we follow people from baseline until the earliest of outcome, 10 years after baseline, loss to follow-up, or end of the study period, which is end of 2019. We consider loss to follow-up as either lack of a known address outside of long-term care or not having a primary care visit in the VA in the previous 18 months. In the target trial, we would be interested in both intention to treat effect and per protocol effect. And in emulation, we estimated the observational analog of the per protocol effect. For statistical analysis, in the target trial, we would estimate the intention to treat risks using pooled logistic regression model with IP weights to adjust for pre-baseline or post-baseline prognostic factors associated with loss of follow-up. In per protocol analysis, we would do the same, except the model would be fit to the data after censoring individuals when they deviate from their assigned treatment strategies. And we would use IP weights to adjust for pre- and post-baseline prognostic factors associated with both adherence and loss to follow-up. We would use non-parametric bootstrapping with 500 samples to calculate confidence intervals, and we would conduct subgroup analyses by age, sex, and race. In emulation, we did the same with adjustment for baseline covariates to emulate randomization. To evaluate potential impact of residual confounding, we also did a secondary analysis using exact matching approach. Basically, we emulated another target trial that randomly assigned individuals to treatment strategies within strata defined by the following, including calendar month, basic demographics, frailty status, herpes zoster, history of herpes zoster, flu vaccination in the previous year, and lifestyle factors. We match Zostavax vaccinated in 1-to-1 ratio with unvaccinated using these baseline factors. And these are the minimum set of factors that we match on to achieve covariate balance in the matched set. Then we calculated risks using Kaplan-Meier estimator, and in per protocol analysis, we truncate the follow-up of a matched pair if and when either member received a herpes zoster vaccine after baseline. One more detail to mention is that we applied an assumed 15-month lag in dementia diagnosis. This is to account for the delay between symptom onset and diagnosis recording of dementia. Based on chart review of randomly sampled 50 individuals, we found that 15 months is the average time from first prescription of galantamine or donepezil, these are typically prescribed when symptoms emerge, to the appearance of dementia diagnosis code in the clinical chart. By doing so, we aim to capture the dementia onset. And now I will present the results. We started with 6.3 million veterans aged 60 years or older between June 2008 and December 2018 with known race and sex. After applying the eligibility criteria that I introduced earlier, we ended up with 64,000 individuals vaccinated against Zostavax and 2.1 million individuals unvaccinated during their first eligible month. Their baseline characteristics are similar between the two groups, except there's different distribution in geographic locations and baseline year. If you look at this figure on the right, we can see the unvaccinated group shown in orange had earlier baseline when they first became eligible compared to the Zostavax group that's shown in blue. Additionally, a vaccinated group is on average younger, more likely to be never smokers, less frail and less likely to have comorbidities, and less likely to have markers of health and healthcare-seeking behaviors. We use dementia in the first 6 months of follow-up as a negative control outcome. It's because this shared similar confounding structure with our main outcome, and we don't expect effect of the vaccine this early on. We found similar risks of this negative control outcome in the two groups, and with the same result in secondary analysis with exact matching approach, which suggests limited residual confounding. We also did analysis using Herpes Zoster diagnosis as the outcome to benchmark to a randomized trial, shingles prevention study. This trial enrolled over 38,000 people at age 60 years or older at VA sites and non-VA sites. They randomized people to receive either Zostavax or placebo in 1-to-1 ratio. They reported 51.3% relative reduction based on incidence rate. They have a max follow-up of 4.9 years. In our study, we reported 41% relative reduction of herpes zoster 5-year risk. These two relative measures may not be directly comparable because one's based on incidence rate, one based on risk. It may be more straightforward to compare their Kaplan-Meier curve to our risk curves in the first 5 years. As we can see, the risks among the vaccinated group are similar, but our unvaccinated group had slightly lower risk than their placebo group. This may be because of the under-ascertainment of herpes zoster event in our population, especially among the unvaccinated group. For our CAUSAL dementia outcome, we found comparable risks in two groups, with risk ratio of 0.96 and slightly lower from the secondary analysis with exact matching approach. We also found similar results within subgroups of age, sex, and race, and in most sensitivity analyses, except two analyses. First, when we use alternative way to incorporate death as a competing event by censoring upon death, we saw lower risk ratios in both primary and secondary analysis. And second, when we adjust for fewer variables, namely with calendar month only, or with minimal adjustment with just calendar month and basic demographics, we saw earlier smaller risk ratios than in primary analysis. For all-cause mortality, we found higher risk of death among the unvaccinated compared to vaccinated. We did expect similar risks, at least for the first 5 years, based on the results that reported in the randomized trial. But instead, we reported a risk ratio of 0.75 with early risk separation, which may indicate potential residual confounding for Zostavax and death. We also obtained similar risk ratio from the secondary analysis with exact matching approach. To summarize, in this study, we found comparable dementia risks comparing Zostavax vaccination versus no vaccination, with limited evidence of residual confounding for this outcome. The estimates remain robust for modifications in sensitivity analyses and with exact matching approach. We also saw noticeable impact of how death is incorporated as a competing event. We observe higher risk of death among the unvaccinated group with implication of residual confounding for Zostavax and death. However, this may be due to different confounding structure for dementia and mortality outcomes. Lastly, I'd like to thank the following co-authors, collaborators from the VA-CAUSAL team for their contributions, and other members of the CAUSALab team for their support and help throughout this project. Thank you.